This video demonstrates ways that principles of kinesiology can be used in the physical rehabilitation of persons following a spinal cord injury. This is an educational resource intended for healthcare professionals, with the ultimate purpose of increasing the quality of life of their patients. According to the National Spinal Cord Injury Statistical Center in Birmingham, Alabama, approximately 11,000 persons survive a spinal cord injury each year in the United States. 39% of these cases are caused by motor vehicle accidents, while 45% are caused by acts of violence or falls. Spinal cord injury occurs 4 times more often in males than females. The average age of a person who sustains a spinal cord injury is 32 years old. However, over half of all injuries occur in persons between the ages of 16 and 30. In the United States, the majority of all individuals with a spinal cord injury live a near normal lifespan. An injury to the spinal cord can cause marked disruption throughout all the systems of the body. This video focuses on the deficits within the motor and sensory systems, and in particular, how these deficits limit functional movements. Spinal cord injury can result in either quadriplegia or paraplegia, depending on the location of the neurologic lesion. Quadriplegia, also referred to as tetraplegia, is defined as muscle paralysis and/or loss of sensation involving the arms, the legs, and the trunk, below the level of an associated injury to the spinal cord. Paraplegia is defined as muscle paralysis and/or loss of sensation involving the lower extremities and, depending on the level of spinal cord injury, the trunk. Most persons with a spinal cord injury enter a formal comprehensive rehabilitation program. The primary goal of such a program is to maximize their ability to function in their homes and communities. Physical rehabilitation, one important component of the overall rehabilitation process, challenges the person to move as independently and effectively as possible, regardless of the extent of the paralysis. Greater mobility often results in greater functional capabilities, which, coupled with a positive attitude, can improve the quality of one's life. Kinesiology is the study of human movement. The healthcare professions of occupational therapy, physical therapy, physiatry, and recreational therapy use this body of knowledge as a fundamental part of the physical rehabilitation process. This presentation features several persons with mid-level quadriplegia who demonstrate how these kinesiologic principles can affect the efficiency of their movement. Understanding how these principles can enhance their functional potential is a fundamental theme of this program. Research will undoubtedly lead to significant improvements in the control of functional movement following spinal cord injury. These improvements may stem from advances in medical treatment, bioengineering, laboratory research, and computer-assisted technology. In conjunction with these advancements, innovative therapeutic approaches may further promote the return of motor function. Although promising, these efforts will take considerable time and financial resources, and may offer only limited benefit for some persons. It is important, therefore, that health professionals continue to research and teach kinesiologic principles that maximize the ease and efficiency of functional movement, regardless of the extent of paralysis. This video features 11 subjects with quadriplegia, each functioning at the C5, C6, or C7 motor level. Based on the classification system designed by the American Spinal Injury Association, or ASIA, all subjects are classified as either ASIA Class A or B. That is to say, the subjects have no motor function and varying sensory awareness below the level of their injury. Individuals were chosen for this project based on their ability to demonstrate specific kinesiologic principles. The functional abilities of the subjects vary considerably based on factors such as personal history, motor and sensory injury level, body type, time since injury, athleticism, and problem-solving skills. At the time of filming, subjects' time since injury ranged from 6 months to over 20 years. This video was produced by the combined efforts of 3 sources. Marquette University's Physical Therapy Department in Milwaukee, Wisconsin. The Zablocki VA Medical Center, also in Milwaukee, and the Paralyzed Veterans of America, based in Washington, D.C., who funded this project. This video presents a blending of academic and clinical perspectives. Dr. Donald Newman is an associate professor in the physical therapy department at Marquette University. Much of his writing, research, and teaching has concentrated on kinesiologic issues related to movement dysfunction and physical rehabilitation. Ms. Michelle Lanouette is a physical therapist at the Zablocki VA Medical Center. She specializes in the physical rehabilitation of persons with spinal cord injuries, beginning immediately following injury and continuing throughout the patient's transition back into the community. This program consists of 2 parts. Part 1 first reviews the muscle function at the C5, C6, and C7 motor levels. This is followed by a demonstration by subjects of the selected kinesiologic principles that pertain to movement and the maintenance of important functional positions. These principles are presented in a proximal to distal order, starting at the scapulothoracic joint and ending with the wrist and hand. In Part 2, subjects demonstrate how the kinesiologic principles are used to facilitate functions, such as transferring to and from a wheelchair, rolling, and coming to a sitting position. It is important to realize that the subjects shown in this video are medically stable and have completed their formal physical rehabilitation program. The functions demonstrated in this video are not necessarily appropriate for all persons with a spinal cord injury. A qualified medical professional needs to assess the appropriateness of such activities for each individual. These activities are usually performed as part of a physical rehabilitation program. Parts 1 and 2 focus primarily on the technical aspects of functional movement following a spinal cord injury. Equally important, however, is the motivation and commitment required to master these movements. These important characteristics will be addressed further at the conclusion of this program. In order for the clinician to help maximize the movement potential of their patients, it is necessary to adequately assess their motor level. This assessment facilitates communication between clinicians, provides objective information on the neurologic status of the patient, and offers insight into the movement and functional potential of the patient. A patient's motor level is assessed by using criteria set by the International Standards for Neurologic Classification of Spinal Cord Injury. These standards are available through the American Spinal Injury Association. Based on this established criteria, a motor level is designated by the strength of key muscles. A patient functioning at a C6 motor level, for example, would demonstrate a muscle strength grade of at least a 3 in the wrist extensors, a key muscle demonstrating C6 innervation, and a grade of 5 in the elbow flexors, a key muscle demonstrating C5 innervation. This section will show the assessment of the C5, C6, and C7 motor levels. Realize that an assessment of a motor level is only one component of a neurologic evaluation. Sensation and reflexes, for example, must also be considered.
We're going to do a muscle test on Brian to establish his motor level. I think we'll start out by asking Brian to shrug his shoulders and relax. Come up again and relax. One more time, lift up. Now don't let me push down, hold, and relax. Give that a 5 grade. Basically, I'm testing trapezius, and that's innervated by a cranial nerve 11 plus some upper cervical nerves. Obviously that he's breathing fine. He has C4 innervation, which innervates the diaphragm. So basically I would address the next level would be at C5 to test. And you can do that with a couple key muscles. One is to look at the shoulder and have him just abduct, pull up like this. Now hold it there, hold it. I'd give that a 5 level. And that really is testing the deltoid supraspinatus group. Doesn't test the whole shoulder because of lack of scapular stability that actually would interfere with the validity of that test. But if we look at the elbow flexors, why don't you bring your hand to your mouth? Good. Now pull up again. It goes through full range of motion. Now don't let me pull you. Hold and relax. Let's do that against gravity now, all the way through full range of motion. Don't let me pull. Hold. And give that a 4 grade. So I know that he's got motor function down, including C5. The next myotome distal to that, I would test his C6 myotome through wrist extension. And what I would ask you to do is bring your wrist in this position. Okay, pull. And relax. Again, extend the wrist. Okay, I would give that a 0 grade. There's no palpable muscle activation there. I would say he does not have any function at the C6 level, but he does have at least a 3 grade. I mentioned before a 4 grade at the elbow flexors, so he would be qualified as a C5 spinal injury. Now, you showed me earlier that you had ability to extend your wrist through kind of a trick motion. What did you do there before?
Extended my arm straight forward and let it go.
Did you do that again? Okay.
Motion straight forward.
And this is a very interesting substitution here. Really what he's doing is he's extending his elbow by allowing gravity to extend his elbow, really. Partially using biceps to supinate and letting gravity extend his elbow. And he's actually stretching the wrist extensors as they cross the elbow, which is expressed as a wrist extension motion. So it's a real interesting kind of natural tenodesis that he's developed. Why don't you try that again? So you have to be careful about some of the trick motions here. So that's why when you test wrist extension, you really have to stabilize joints proximally. And now ask to, how extend the wrist now? And there's no activity at all. I'm going to perform a muscle test on Kurt's left arm to establish his motor function. I first want to start at C5 to assess the C5 function. I'm going to ask him to abduct your arm, bring your arm up to the ceiling. Now hold it there, hold it, and that's a 5 grade. Next muscle to assess the C5 myotome would be elbow flexion. How about bring your hand to your mouth and relax. Pull again. Now hold and relax. Another 5 grade. That combination of 5 grade at elbow flexion and shoulder abduction really verifies very strong C5 function. To check the C6 myotome, I'd start with wrist extension. If you cock your wrist up and relax. Now bring it up again. Now hold it there and relax. Now if you pull that up again, cock up, notice he has really a strong radial deviation tendency. And back down, up again, and down. Now the radial deviation tendency kind of gives me a clue that he has radial wrist extensors functioning, which are C6, and not ulnar wrist extensors, which are C7. But nevertheless, pull up. I'd give him a 5 grade as far as wrist extension. So that tells me that he's definitely got well-developed C6 function. And to double check that, I like to go to the clavicular head of the pectoralis major. You can see his well-developed anterior deltoid. It tells me he has at least C5 function. And this well-developed also gives me a clue that it's really C6 as well. But the clavicular head of the pectoralis major is going to be noted right here. And if you bring your arm up over to the other side and relax, good. Pull over and relax. Now hold. One more and hold. Don't let me pull. Hold and relax. Now that shows me really good C6 function because I can definitely palpate the tension in the clavicular head of the pectoralis major. Now, I would next want to check a C7, the C7 myotome, and I would do that by checking for wrist flexion. How about if you would just try to bend your wrist and relax. Bend again and relax. I'd give that a 0 grade. And as far as triceps, how about if you move your forearm, just try to stay right level with the floor here, and you kind of touch my hand. Push and relax. Push again and relax. And I'm palpating just a trace muscle contraction on that. I'd give that a 1 grade. You've probably learned to substitute and extend your elbow in another fashion, haven't you? Why don't you just, and how is it you're able to do that?
I think I just raise the hand up a little bit and let gravity take it down, and then once the elbow's locked, you just kind of twist it around a little.
But if I don't allow you to do that substitution, you really can't extend it. And really what he's doing here is he's flexing it first, and then just by relaxing the biceps, just the passive tension of the triceps kind of gives an indication that he's actually extending, but he's not. We're going to do a muscle test to establish Frank's level of function. And the first test I want to do is test elbow flexion, which is going to test the integrity of his C5 myotome. How about bring your hand to your mouth, Frank? Okay, now hold there. Don't let me pull. Hold, hold, and relax. That's a 5 grade. Now, to test the C6 myotome, I would check wrist extensors. How about cock your wrist up? Now hold it there. Hold, 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 and then relax. That's another 5 grade. And then to check the C7 myotome, a couple muscle choices we have here. One is wrist flexion. How about bend the wrist? All right, so it bends against gravity. Now hold. And only takes minimal resistance, so we'd give that a grade of 3+. Now I want to check his triceps, which is another C7 test. And I think I'll start going against gravity here. How about bring your hand to the ceiling? All right, so at least a fair. Now hold there, hold, and he just breaks with minimal resistance, so that would be a fair plus. And how about repeat this exercise 10 times? Just reach up. 1, 2, 3, because sometimes it's interesting to watch how rapidly someone will fatigue. I think that's 6, 7, 8, 9, 10, about 3 more. Okay, so basically he has about 10 or 11 elbow extensions. So when you're muscle testing something like this, in this situation, you really need to make sure you haven't fatigued the person beforehand, or you may get a spurious result. So to go down now to C8, what I would go ahead and try to check finger flexion. So why don't you do me a favor and curl your fingers around my fingers. Squeeze and relax. Squeeze again and relax. So there's no action in your fingers. You can't close your fingers. Can you move your fingers any way around at all? Can you do anything with your fingers at all? No? Okay. Now how about try to make a grasp? Like you're going to squeeze my finger. Any way you can. Squeeze. Notice that he extends his wrist here to load the finger flexors, and we call this a tenodesis grasp. But I don't see any active volition in C8-driven musculature. So we'd classify you as a C7 function, and probably a relatively weak C7 because you only had a fair plus in elbow extension.
The scapulothoracic joint is an interface between the upper extremity and the trunk. As a result of muscle weakness, the scapula may lose its fixation to the trunk and become unstable. Subsequent proximal weakness can reduce the functional potential of the entire upper limb. An unstable scapula due to weakness of the serratus anterior, for example, reduces the efficiency of performing certain activities, such as a sitting push-up or transferring between a mat and a wheelchair. This section includes the following topics: the role of the serratus anterior in scapulothoracic protraction, muscular interaction of the shoulder with an emphasis on performing a sitting push-up, and the mechanics of a winging scapula.
We're going to show some important functional considerations of the serratus anterior. And the serratus anterior, if we recall, originates off the lateral part of ribs 2 through 8. and the muscle then goes on the anterior side of the scapula to attach to the whole medial border. So the muscle tends to have a line of pulls such as this. So the muscle is driven primarily by C6. So Angela functions at the C7 level. She has a really well-developed serratus anterior and doesn't demonstrate a lot of, and really any winging. But to show how this muscle works, if you were to just kind of push straight to me, now make your arm short, now push straight out. Now notice this functional elongation of this upper limb. This really is a protraction motion of the scapula. The scapula is protracting, pushing the glenoid, and therefore the whole arm forward. Now the reason why this is such an important motion, because this motion really is transferred really into this motion for a sitting push-up. It's just really the direction changes. And then when you're actually doing the sitting push-up, you also involve the lower trapezius. So this is an important functional motion, and this is often how you can individually test the serratus anterior activity. I want to show some activities that really can challenge this whole scapulothoracic protraction. This motion I'm showing right now is a nice way, but there's one way we can also do that where the person is actually prone on elbows. So if you wouldn't mind, if you could get prone on elbows for me. Okay. Now, as we said before, the serratus anterior muscle really is anchored to the whole medial border of the scapula, right through here. And then the muscle actually works its way laterally to the rib cage. Now, if this muscle was to shorten, the freest segment is going to move. The scapula will either protract, or if the scapula is fixed, the thorax will actually be raised up off the mat. In either case, the proximal distal attachments of the muscles are just approximating each other. So it's important to think about this serratus anterior has this function, because if you would lift your chest off the mat real slowly, okay, up, and then slowly back down, okay. What Angela's scapula are doing, they are being protracted at the same time the thorax is actually lifting. So the muscle is really contracting at both ends. The proximal segment's moving toward the distal and vice versa. Why don't you do that a couple of times? Up and back down. So up and back down. So really all I'm doing is just approximating the proximal distal attachments of the serratus anterior. And this is a real nice functional way to challenge this muscle. You can actually load the thorax by putting weight on the thorax, actually give that resistance manually, or use sandbags. Can you try that just a couple more times? Up, good. So the idea is get the greatest distance from the chest to the mat and get as much protraction as you can from the scapula. And if I put my finger right here, you can do a couple more of those. You can see that in maximal protraction, she really is I'll follow her medial borders over to here. A couple more, please. That's it. Good. And relax. Good. Now, sometimes someone may have an asymmetric weakness where they're weaker on one side than the other. And let's assume that we're really going to concentrate on Angela's right side. So if you can kind of just balance your left side, as shown here, and really concentrate on just this side. So this is really a unilateral activation of the serratus anterior. And it certainly challenges all glenohumeral musculature as well. So this is a real good fundamental task to challenge the serratus anterior and all the muscles that actually give stability to the glenohumeral joint. And if you could use that a couple more times, that's it. Pull out against resistance. And then if you could come back and do it with both elbows down. Good, just a couple more. Now hold it up there, and then slowly lowering down is really an eccentric activation of that same muscle. And then if you were to shorten that muscle, bring it up again, and then relax. Okay. Understanding the normal scapular-humeral rhythm at the shoulder really is an important prerequisite to understanding the abnormal mechanics of a winging scapula. Now what we have here is we have the scapula is in its regular resting position, and we have various force vectors that represent different muscles. We have, if you picture the scapula being in this position, we have the serratus anterior muscle that's pulling in this direction, which would be an upward rotator and a protractor of the scapula. This is innervated through the 6th and 7th nerve root primarily. We have the 3 parts of the trapezius, upper trapezius, middle trapezius, and lower trapezius, all attaching from the axial skeleton into the scapula. This muscle group is innervated primarily by a cranial nerve 11. We have a muscle force vector that represents a resultant of the glenohumeral abductors. It could be the middle or posterior deltoid, shown here. This is innervated more at the C5 and C6 level. So we have various muscles of different innervations all have to control the mechanics to bring their arm up over the head. And I'm mentioning this because with a spinal cord injury that you have weakness of the serratus anterior, the deltoid muscle becomes a prime mover. Whenever you need glenohumeral activation, the scapula tends to downward rotate and wing. Winging meaning that the medial border will flare upward. And that winging really is driven by the deltoid not being opposed by a serratus anterior. Now, if the scapula is in this unstable position, which I'm going to show you somewhat in a moment, the lower trapezius then is not as effective of a scapulothoracic depressor, so it makes it more difficult to actually raise the rear end. Now, Kurt has some weakness on this side in C6, and he's able to compensate really very well for his problems in the weakness. Let's first show the normal mechanics of upward rotation. Kurt, if I can get you to just bring your arm up over your head and relax. Now, I'm going to help him out a little bit here, but basically the scapula is going to upward rotate and downward rotate. It upward rotates and downward rotate. Now, the mechanics are the deltoid is going to be the prime mover in abducting the glenohumeral joint. The scapula is going to upward rotate by a force couple being serratus anterior, lower trapezius, and upper trapezius. Now, all these muscles rotate the scapula upward, protect the length-tension relationship of the deltoid. Now, with a spinal cord injury and weakness of the serratus anterior, we have a mismatch of the kinetics. Now, Kurt, if I ask you to do a sitting push-up, okay, and I'll come back down just a little bit, and the mechanics of the sitting push-up requires that this whole upper arm remains stable, not at the glenohumeral joint, so you really have to drive your glenohumeral abductors. The elbow needs to be remained extended, and the extension really is driven by more proximal musculature, and he needs this 90-degree angle at the wrist. If he has this stable pistoning action of the upper extremity, by dropping the head and putting tension on thoracolumbar fascia, it tends to raise the rear end. Now, all that being said, there's an extra assistance of other muscles that occur, primarily the lower trapezius. If you actually try to do that sitting push-up and hold it right about there, notice that his scapula starts to downward rotate and wing. The medial border flares off the rib cage. And the reason for that is that the deltoid muscle now actually pulls the scapula in this direction. You can just take a rest if you want. And then come back up. The deltoid muscle becomes the prime mover of the scapula, rotating it downward when it's unopposed by a weak serratus anterior. From this downward rotated position, the lower trapezius then, which now wants to change its force direction, because when this muscle shortens, it's actually going to raise the rear end, and then relax a second. What I want to do here is have you push down into your wheelchair once for me, and then relax. What he's doing is pushing down in the wheelchair and activating his whole deltoid complex. And the deltoid itself, if it's not stabilized by a serratus anterior, actually takes the scapula into a downward rotated position. And one of the problems of that is it throws the line of pull of his lower trapezius off, so it's ineffective in depressing the scapula. Why don't you try that again? Push down and relax. Push down again and relax. Why don't you do me a favor and just take a couple strokes forward. As soon as he pushes, he has the winging. Okay, now come back to me, please. Okay, Couple strokes back. Good. And then go forward again. Good.
Large physical demands are often placed on the glenohumeral joint following a spinal cord injury. Many functional activities require prolonged and repetitive weight bearing through the shoulders. Shoulder muscles must provide stability to the glenohumeral joint while simultaneously allowing a wide range of joint flexibility. These requirements are essential for maximizing one's functional potential, from pushing a wheelchair to coming to a sitting position. This section includes therapeutic activities that promote strength and flexibility of the shoulder muscles.
We call this position supine on elbows, and it's really an important functional position or posture to be able to assume, because it's kind of a stepping stone to coming up to sitting. So this position, supine on elbows, in order for Jason to be able to hold this position without fatiguing, you have to be able to have enough hyperextension at your glenohumeral joint. So the elbow really has to be posterior to his glenohumeral joint. And if you can get the elbow posterior to the glenohumeral joint, you can actually maintain a stable shoulder purely by passive means, where his line of gravity or trunk line of gravity would fall actually anterior to the joint, and he can just kind of hang into the anterior ligaments, if you will. Now, in contrast, if he had such tightness where he could only bring his elbow to here, in other words, he only had this much extension versus this much extension, this requires a strong activation of his supraspinatus and deltoid group that he eventually would fatigue. So by bringing your elbow into hyperextension, you kind of shut off muscles and you can kind of relax in this posture. Now, ways that you can work on getting this range of motion, one is just being put in this position, supine on elbows. And you have to work at this gradually because this is very difficult. It can be painful in the very beginning following injury. But one way to work on this stretch is if Jason would allow me just to kind of rotate his trunk over this right glenohumeral joint. And you can see I'm just kind of giving that a nice natural stretch, just putting weight bearing through his glenohumeral joint. Very often, glenohumeral joints can become very painful after injury. I think weight bearing is a nice way to try to prevent that. And let's switch that over on the left side. Okay. And it's just giving a nice stretch to that glenohumeral joint. And now back supine on elbows. And another way you can also get a stretch for the same activity is bring your arm behind you a little bit. Okay, and then the same thing with your left arm. Okay. You all right with this? Mm-hmm. Okay. Now again, just being able to sit and tolerate this stretch right here is very, very helpful. All right, this also is a nice stretch for the biceps as well. And again, picking on just the right side, we can rotate his trunk over the right side. And that gives it even more of a hyperextension stretch on that right shoulder. And very often it's helpful to have a mirror that I can be looking in to make sure that Jason's not grimacing too much and this is not an uncomfortable position. You certainly have to use your clinical judgment before you do activities like this. He certainly needs to be free of severe pain. He has to have a stable shoulder. Cannot have osteoporosis in his upper extremity. It's all right. So I'm actually getting his left shoulder through the weight-bearing stretch and also the right shoulder through my manual technique. But I need to emphasize this needs to be done slowly and gradually before you can get this physical here. Okay, how about walk up to sitting from here? We like this position to actually perform exercises from as well. We really need to develop a stable and a mobile glenohumeral joint really bilaterally. Now, one way to actually do that is to bear weight, as shown here, and other activities is actually to move in various positions. And we're going to start by having Jason just go supine on elbows to prone on elbows in just a series from one mat to the next. And notice how he pivots over his left elbow, touches down on his right, challenges now his right glenohumeral joint, touches down on his left elbow, And this is a very high-level activity that Jason has learned, which took him quite a while to master this. I don't think you have another roll in you there. Okay, we'll turn around. This really challenges both the mobility and the stability of both glenohumeral joints. Okay. Is this uncomfortable on your shoulders at all?
No,
No?
not right now.
Not right now, okay. What I want you to do is try to rotate back onto your back, but pivot over this left elbow. And we'll break this up into steps. The first idea is, can you just lift your right arm up and kind of like this? Relax the arm, just like this, and now back down. Okay, lift up, kind of like this. Now stay in that position, good, and back down. Lift up. Okay, even holding this position really puts a challenge on this left shoulder here, your weight-bearing shoulder, and relax. Lift up and back down. Okay, the next step is we'll lift up again. Now you want to start pivoting over the shoulder. Good, just that's far enough, beautiful, and then back down. And really this ball and socket joint here, right on the left, is a pivot point. Good. And relax. So you're pushing with your right triceps to extend that elbow. And the real pivot point is this shoulder right here. And relax. How does this feel on the shoulder?
Okay.
All right?
Tired though.
Just kind of tired? Okay. Okay, lift up now. Once we get to here, can you continue to pivot around? Now the idea is to touch with your right arm to this side. Just touch down once if you can. Touch down. Good. Now come back again. Touch down your right elbow. I'm sorry, your right elbow right here. That's it. Good. Now pivot down and just touch down on the right side now. Just touch down. Now come over and touch on your right elbow. Okay, good. Now we'll try to come all the way around now. Come all the way around. Okay, good. And we're going to have to try to come back on your elbows. I'll pull this shoulder back. Okay, good. You all right?
Yeah.
Good. Now once we have this posture, we need to move from this position. Just like the hip needs to be stable and mobile, so does the glenohumeral joint in a limb that functionally bears weight. So, Jacqueline, what I want to do is I want you to kind of think about pivoting over this shoulder and put the tip of your right elbow right here. Okay? That's good. And let's see if we can then just kind of bring your hips along with you. Good. And we'll be on this prone on elbow position. Good. And then let's try to do that. Let's keep that up now. Now pivot over your right elbow. Keep this elbow vertical. That's it. Good. Beautiful. Okay, now bring your tip of your right elbow back down. Good. Beautiful. Let's try to reach out again and do that again. Reach out. That's it. Okay. Okay. Good. Pivot over the left elbow. Now come down on the right. I'm sorry. I'm sorry. Come out. Come. Good. Good. And then we'll just kind of bring the legs over. A little bit more. Good. And rest. Now let's head the other way. You got it? Let's try to head the other way now. Good. Now come back on the right. That's good. Now reach out now. Good. Good. Okay, reach out with that arm so your hips follow you. Reach out. Way out here. Reach, reach, reach. Okay, just one more. One more. Good. We'll just end up back supine and elbows. Okay, reach out here like we started. And good. All right, great job.
The elbow functions as the middle link of the upper extremity. Elbow flexion is essential for performing many important activities of daily living, such as feeding and grooming oneself and pushing a wheelchair. These activities require adequate strength of the elbow flexors. Elbow extension is necessary to augment reach and provide a mechanism to transfer weight through the upper limb. Persons who function at the C7 and below motor level typically perform these actions with innervated triceps. Persons who function at the C5 and C6 motor level, however, that is limited or absent triceps innervation, must use other strategies to extend and/or lock the elbow. One strategy involves the use of shoulder muscles as a substitute for the lack of triceps innervation. This strategy requires that the elbow is free of a flexion contracture. This section includes the following topics: the role of the shoulder in stabilizing the extended elbow, performing active elbow extension with and without triceps innervation, consequences of an elbow flexion contracture, and deltoid to triceps tendon transfer.
We're going to talk about some concepts that relate to elbow joint stability. The first idea I want to emphasize is that Brian has the ability to extend his elbow, even though he does not have triceps, via more proximal musculature. And he can do this as long as the distal segment is fixed, like I'm holding here. He contracts a muscle like the anterior deltoid. The humerus is actually going to be brought across the midline, and it's going to bring the elbow into extension. About push me away. So this really is a way of active elbow extension governed by more proximal musculature, a very important point. So really the anterior deltoid really becomes a triceps substitute. Now this can only occur when this distal limb is stable. Push again. So if we bear weight over this extremity here, and we flex him slightly, okay, now straighten up. Okay, I'll pull you into flexion a little bit. Now straighten up. One more time, I'll pull you into flexion and straighten up. So this whole mechanism really allows him to have elbow stability, which is a very important part of assuming this short sitting position. Now, if Brian developed an elbow flexion contracture, which he's very susceptible to because he has elbow flexors and not elbow extensors, if he developed an elbow flexion contracture, he really couldn't utilize this principle. It would be very difficult to him even if he could get his anterior deltoid to contract, he would never get the elbow in full hyperextension that he could mechanically lock the elbow. So this middle link of this whole upper extremity is very important. That can be stabilized by proximal musculature. Now, that's really talking about some active control of this joint as far as elbow stability. Now, very often he has to assume even passive stability in this joint. And one idea to notice here is if Brian is in relative internal rotation of his shoulder, as such right here, where the medial lateral axis of rotation now is shifted somewhat in this position, now his line of gravity now, due to his trunk weight, falls anterior to some medial lateral axis. So gravity itself then causes this elbow to flex. All right, so if I push over this side, you can see he does not have stability because I'm pushing now, and I'm pushing with a force that falls anterior to the axis, and it tends to collapse the elbow, and his anterior deltoid is really not in a good position to resist that. Now, if I externally rotate his whole upper extremity, as shown here, by externally rotating the upper extremity, now the joint is much more stable because now the line of gravity due to his body weight then falls behind or posterior to this medial lateral axis. Now when I push down and give him kind of a compressive load through the extremity, he stays stable. And once again, this requires him to have a fully hyperextendable elbow such that line of gravity can fall posterior to the elbow. Very similar to how someone can stand on a stable knee without quadriceps. Very, very similar, as long as they don't have a knee flexion contracture. So the point here is that shoulder range of motion is very important prerequisite to elbow stability. If someone has tight internal rotators, basically, and they cannot get into external rotation, their elbow is relatively unstable. So external rotation at the shoulder really sets up a lot of the biomechanics for elbow stability. Let me push, don't let me push. And this is very, very important because it gives him this way that he can stabilize his short sitting position even without triceps. Stephanie has C6 function on her right without any triceps function. She has C7 function on her left with a 3+ grade triceps. So she really is in position to show and contrast the function of elbow extension without triceps and elbow extension with triceps. And one of the first things I want to show, if Stephanie, if you could put both your hands up right in front of you there, and if you just hold on to that posture a minute, what we're going to ask Stephanie to do is to actually go into flexion and extension. And I want you to note the difference of her right side and her left side. Basically, when she brings her head down to the mat, she's going to use eccentric activation of her left triceps. But on the right side, it's going to really be eccentric activation of her anterior deltoid. It's going to let the humerus drift away from the midline, bringing her elbow into flexion. And then when she goes into elbow extension, on the left, it's going to be through a concentric contraction, primarily of her triceps. But on her right side, you'll notice that she'll really try to externally rotate her humerus such that she can have gravity fall, the gravity of her superimposed trunk, fall behind the axis of rotation. And the actual torque that drives this elbow extension is going to be more proximal musculature. The anterior deltoid, clavicular head of the pectoralis major contracting, bringing her into extension. So why don't we show that, Stephanie, if you would just kind of flex. That's it. Just see if you can do a couple of those. Now, notice here on the left, this is driven primarily by elbow extension because she has triceps, even though only strength to the 3+ level. On the right side, you'll notice that she performs much more of a horizontal adduction motion. How about, could you bring your arms a little bit closer to the midline and do that a couple more times? And notice when she comes up into extension, she externally rotates her right shoulder a little bit more. Once again, so she can help with elbow stability. If you hold it right there, when she's externally rotated like this, now her gravity falls behind the medial lateral axis of rotation. If she were to internally rotate, you can see the elbow tends to collapse because gravity then falls on the anterior side of her axis. An elbow flexion contracture really can be prevented. And the reason why he was set up for one is because he has elbow flexors and not elbow extensors. That's just a basic, a really important kinesiologic principle. The joint is going to naturally want to deform towards the area of strength. If he doesn't have triceps and he's not naturally bearing weight, he has no natural way to extend his anterior capsule, and eventually the joint is going to deform towards a flexed position. So there really is a stability issue here, particularly without triceps. Now, not being able to bear weight over this arm certainly interferes also with that whole scapulothoracic thrust motion or protraction motion like this, which is required for a sitting push-up. You bear weight through that extremity, and the elbow just collapses into flexion. Jason's going to show the benefits of a surgery that he had that consisted of taking motor power from his posterior deltoid and routing that to his olecranon to actually give him elbow extension. Jason functions at the C6 level bilaterally and doesn't have any triceps actively at all. So this is an interesting surgery, really, that you actually take or borrow, really, muscle power from an innervated muscle, such as the deltoid, that's innervated at C5-6, and harness that to drive an otherwise action that's not possible, elbow extension, at least not possible as he's shown right now. So as we can see right here, as he contracts his posterior deltoid, that force then is routed through the iliotibial band. A section of his iliotibial band has actually been taken from his leg, and that's connected into where the triceps would insert. How about relax? Push out to me. Now hold and relax. And you certainly can see this well-developed posterior deltoid, part of the iliotibial band, and it attaching into the olecranon. Jason, how about put your arm up over your head and bring your arm straight to the ceiling. Now hold there and relax, and he gets a good 4 grade. It's interesting that he still has the ability to do the primary action of the posterior deltoid, pull back again, without his elbow extending. Relax, pull back again, and relax. The 2 reasons for that is only part of the posterior deltoid is actually routed into the iliotibial band, and as you can see, he contracts his elbow flexors to limit some of the otherwise tendency for the posterior deltoid to extend the elbow. But it's really worked out well for Jason. How has this helped you in functional activities?
Well, one thing it's done when someone who doesn't have triceps, before the surgery, when I'd raise my arm up at this point, when I'd hit gravity, it would just flop down. So it gives me the ability with both arms to put above my head. So it gives me more stability when I'm reaching out to grab things, instead of I would have to do the snake or compensate and then externally rotating, grabbing things. It's also helped with dressing. If I have to dress and pull a t-shirt off, I would put my arm in here and extend and pull that way. So when I was going back, it gives me more power and more efficiency when I'm doing things, grabbing things. It makes things a lot quicker.
Sure.
The wrist and hand in persons with mid-level quadriplegia are often subjected to physical stresses that are similar to those applied to the ankle and foot of an ambulating person. Both regions are the primary weight-bearing surfaces of their respective extremity. Similar to a foot drop in the ankle, paralysis of the wrist extensor muscles reduces the ability of the hand to adequately accept and disperse compression forces. The ability to obtain a wrist-extended position is therefore an important goal following spinal cord injury. This can be accomplished through strengthening exercises, splinting, or, when appropriate, tendon transfer surgery. Wrist extension forms a functional hook that can help fix the distal end of the upper extremity to surrounding objects. In addition, active wrist extension adjusts the passive tension in the paralyzed finger flexor muscles. The increased tension can be used to power a functional grasp, often referred to as a tenodesis grasp. This action applies not only to facilitating finger flexion, but also a key pinch between the index finger and the thumb. This section includes the following topics: the importance of active wrist extension, the tenodesis grasp, benefits of using a static wrist extension brace, and tendon transfer to improve key pinch.
Now, working down his upper extremity, we talked about the shoulder, we just talked about the elbow, and it's important also to talk about the wrist. Okay? Now, the wrist really needs to be extended to close to 90 degrees, 70 to 90 degrees, so that you can actually have a surface to bear weight. All right? Now, notice that when I push him, his elbow does not break into flexion. We just made that point earlier about the stability he has as his elbow, but I'm only able to get an effective thrust up through his extremity because I have this platform to push through. So it's important that past the range of motion that you have about 70 or 80 degrees, or even sometimes up to 90 degrees of extension. Now, so the wrist is really important. At C6, you start to gain two very important groups of muscles. The serratus anterior, which if you don't have very effective C6 myotome, you tend to have a winging phenomena. And what happens there is the scapula tends to be unstable, and it's inefficient then to transfer that load distally through the upper extremity. But C6 function that Bob has, you start to get a stable scapula, and you start to get wrist extensors. Both of those activities on either end of this link are really essential for the independence that Bob shows, for the ability to come to sitting, transfer, and push his chair as well as he does. So the wrist extension is important for several reasons: to hold this wrist extended position so you can place your extremity in an adequate fashion. It powers the tenodeses, right? You can't really use the tenodeses unless you have an active wrist extensor to stretch the finger flexors. And thirdly, it really acts as a hook that increases really the functional utility of the whole upper limb. Now, if you want to go down on that elbow, just down, now pull up and go back down. So he's using really a combination of elbow flexion and wrist extension, but if he didn't have wrist extensors, my grasp would have to be on his forearm. Let's come back down again. And I would have to then work on the next highest level musculature, which would be C5. Pull. Right? But since he has wrist extensors, then he has a much longer reach. Now pull up and back down. Pull up and back down. And then rest. And how about if you just make a grasp any way you can? And then open your fingers up. Now make a grasp and relax. Now, it's quite obvious that he's actually making a grasp by extending his wrist. By extending his wrist, he actually stretches his long finger flexors. And that stretch then passively loads his finger flexors. We call that a tenodesis. Hold and don't let me pull, and relax. We see as a nice functional grasp right here, but it's not driven by an active contraction of the C8 driven finger flexors. It's all done passively, and he really has to have this wrist extension to actually power that tenodesis. I also notice when he goes, his wrist drops into flexion, which really gravity is allowing that in this case. His index finger extends. When his wrist extends, the index finger flexes slightly. But when I flex his wrist, it puts passive tension on his extensor indicis, which tends to extend the index finger. So really, tenodesis really does work in not only wrist extension by passively making the fist, but by wrist flexion, it helps passively load the extensors. Okay. So really, that's one of the major problems of lack of C6 myotome is the lack of wrist extension. Now, it's important to brace and try to compensate for what's weak. So there's actually wrist extension splits you could use to actually give stability to the wrist. And actually, this is, I'll just put this on kind of partially here, but this is a wrist extension substitute right here that gives him some static stability anyway into wrist extension, and it holds his wrist in a neutral extension, and that allows him, his finger flexors, to have some tightness, because if his wrist was in a dropped wrist position, he would not have any passive tension in his finger flexors. So this gives him somewhat of a functional hook using his finger flexors. So it's important to actually stabilize the wrist into extension. Otherwise, you would just stretch out the wrist extensors. You would not be able to utilize any passive tension in his finger flexors because they would not be stretched. And this, a cuff like this allows activities to be performed, such as feeding, for example, or other activities. Right? What other activities do you use with this cuff?
I am able to put a toothbrush in there, help me brush my teeth. I also put a sandwich holder in there. And I even can write a little bit by sticking a pencil or a pen in there.
And you said shaving too?
I shave by putting a sleeve over the top of my hand and then lifting up like this.
Now the thumb, which is a very important component of the hand, also is involved in this tenodesis action. If I can show on my own hand, when you actually extend the wrist, as shown here, the fingers automatically flex. Now the flexor pollicis longus is also stretched when you extend the wrist. Now very often the tension in the flexor pollicis longus is not adjusted correctly, just naturally, to actually give you a nice key pinch. The idea is that when the wrist goes into extension, the fingers curl, but the thumb also flexes, such as the flexor part of the thumb approaches the middle phalanx of the index finger, or the radial side of the index finger, the so-called key pinch. So this is ultimately what you would want. So this was actually helped out by a surgery, and the surgery basically takes the flexor pollicis longus muscle and separates the muscle from the tendon. Then the distal tendon is actually, the proximal side of the distal tendon is actually run through two little holes that are placed in the radius, and the tension then can be adjusted, the passive tension can be adjusted in that tendon of the flexor pollicis longus. Then when he contracts his wrist extensors, there's adequate tension in the flexor pollicis longus to actually flex the thumb. So the thumb approaches the radial side of his fingers. Now some other aspects of that surgery is sometimes the pulley at the metacarpal phalangeal joint is cut so that the flexor pollicis longus tendon bowstrings away from that axis, increasing its mechanical advantage. Sometimes the extensor mechanism is actually tied down, limiting flexion at the MCP joint. And almost always a pin is placed in the interphalangeal joint. Then the pin is later removed, and then this joint is fused. So Jason shows this activity real well. If he extends his wrist, he actually has a very substantial pinch between his finger and his index finger and his thumb. Now bend the wrist. Now cock the wrist up. Now bend. So bending the wrist then slackens that distal tendon of flexor pollicis longus. Extending the wrist puts tension in it. And that's a very functional grasp right here. Now it'd be nice to compare this to Jason's left side, where this procedure was not performed. If he extends the wrist now, you can see that there's a gap here. There's just no passive resistance to his flexor pollicis longus, even though the flexor pollicis longus is stretched because the wrist is extended. So really, this shows an excellent example of how this surgery is intended to actually function. Now we can show a couple of functions here. Why don't you, Jason, grab that water bottle? And obviously, that's a very secure grip. And if you were to give it to me, just flex the wrist, I guess, and that kind of opens up. And you compare that to his left side. I'll just put that on your lap and let you.
The only way I can do it is by supinating and bringing it up.
Okay. And then why don't you try that on your left again? Now this obviously requires active force in the wrist extensors. Sometimes the brachioradialis is divided distally and put into the carpal bones to power wrist extension if that's also weak.
The long sitting position is an important functional posture for a person with a spinal cord injury, serving as an intermediate step between lying down and sitting upright. The position also provides a stable base of support for the body, thereby freeing the upper extremities to interact with the environment. The ability to achieve and maintain the position is an important prerequisite for dressing, performing personal care, moving the body upward and laterally, and transferring to a wheelchair from a bed. And finally, the long sitting position provides a means for performing exercises that improve the mobility and stability of the upper extremities. This section includes the following topics: the long sitting position, a practical means for offering therapeutic challenges; the consequence of tight hamstrings; and the long sitting push-up.
To be in this position, be stable, he has to have enough shoulder extension that he can bring his glenohumeral joint in enough extension that his trunk weight actually falls in front of his shoulders. Now, so you can see how stable he is in this position. All right, it's a very, very stable position. All right, and this is a good position actually to do exercise from because it forces weight bearing through both upper extremities, which tends to reduce the pain in the extremities. And you can do a lot of activities from this position. Like if I pull his arms back and now ask him, how about kind of walk up if you would? Okay, and notice that whole kind of horizontal plane rotation that he uses to do that. I'll pull him back down again. Okay, kind of walk back up again. So I can't overemphasize the point about stability in this long sitting position like this. And come up again. And I'll pull you back again. It's important with hand placement that you allow his finger flexors to, his fingers to stay flexed so we don't overstretch his long finger flexors, and kind of walk up again. Okay. And this position also is nice to actually give range of motion to the shoulders. And it's a real nice functional position to do this, and we'll start on the left side. And basically pull his left arm behind him. And notice that this really hyperextends his left elbow, which is very, very useful. And just kind of rock his body over to the left side. Is that hurting you? Is that all right? Okay. Then we can switch over to his right side. So this gives a nice functional stretch to the glenohumeral joint capsule to allow his shoulders to be in this amount of hyperextension so we can actually support this long sitting posture. Right. And of course, not only this gets the anterior capsule, but it's stretching the long head of his biceps, which is important so he doesn't develop an elbow flexion contracture. And without adequate elongation of his hamstrings, his pelvis stays in a posterior tilt, throwing his whole lumbar spine posteriorly, and the only way he can maintain any balance at all is actually to have his upper trunk overflexed. And the best way to show this idea is from the side with a model. If we assume that this is John's left femur and pelvis right here, in this position he has his pelvis posterior rotated such like this, and that's because of tightness in his hamstrings that I'll show in a moment. So ideally what you need to do is have enough hamstring range, possibly 90 degrees, 100 degrees, 110 degrees of hamstring range, such that when you're sitting in a long sitting posture like this, the pelvis can be rotated anteriorly. If you can get the pelvis in an anterior tilt, then his trunk is anteriorly over his hip. And then the line of gravity then falls anterior to his hip joint, and he really can actually hang on his hamstrings. The problem now is with tight hamstrings and his pelvis posterior tilted, the only way he's going to get his trunk anterior to the axis for actually stability is to flex his thoracolumbar region. So we really need to emphasize on stretching his hamstrings. And even early on in rehabilitation, if the hamstrings are tight, you need to really actually stop the long sitting posture, because once he's in this posture, the only way he can stay stable is to overflex this region. And then it stretches out his low back. And then once you stretch out your low back and the thoracolumbar fascia, then it's very difficult to do a sitting push-up, because when the lower trapezius actually contracts the stable scapula to raise the rear end lumbar region just tends to telescope out, and you really lose the lifting energy from the scapula down through the sacrum. Balance generally is not too much of a problem in long sitting position as compared to short sitting position, because she has such a long base of support. But once you get comfortable in this position, we like to work on a sitting push-up. And why don't you show one of your sitting push-ups for us? And there's a couple stages. The first idea is she's going to get her arms locked and elbows locked. And the second one is actually contracting her lower trapezius and raising her rear end. Notice how she drops her head to bring her rear end up. Tell me the feeling of how the head works into this whole relationship of the push-up.
You just have to wait, go slow until you get to a point where you know that your butt's off the ground and that you know you won't fall forward. And it's a lot of trial and error. It really is, and a lot of getting to know what your body can do.
Right. So it's almost like your arms act almost as these pole vaults almost. And then once they're stable, matter of dropping the head falls in front of some medial lateral axis that would go through her shoulders. The head dropping this way, since the head is connected to the cervical region and et cetera, all the way down to the sacrum through connective tissue, dropping the head manually lifts the rear end. And then when you throw on an active contraction of your lower trapezius, the muscles that actually perform the scapulothoracic depression, you actually get the lift. Why don't you show that just a couple more times? Good. Pull up. Okay.
That was an example of having your head go too far forward.
And as you can see, Angela has very, very loose hamstrings, and she cannot rely on any passive tension in her hamstrings to give her support. How about let's work on doing a sitting push-up where you move laterally from this mat to the next mat, and tell us how the head-hips relationship works in this.
Okay, you put one hand right beside your hip, and then this hand is going to guide where your butt's going to go, and when you lift, you want to move your head in the opposite direction of the way your butt's going to go. So my butt is going this way, and my head is going to go like that. And then you just bring your legs along. And then I'll do the same thing. Leave room for my butt to move. Put this hand next to the opposite hip. And when you lift, swing your head that way.
The further she rotates the head, the more the rear end goes. It really puts a spiral tension through all her thoracolumbar fascia to twist the rear end. Now we can see a little bit more of the lift that you get from this. Okay, so we have our arms rotated outward. Okay, and now kind of drop, good, and back down, good. Try to lower your rear end right before you hit that point that you're going to lose it, good, and back down. Kind of come up, good, and back down, beautiful. And one more, up and back down, great. So if you have just a little energy left, if we could kind of go kind of this way with the sitting push-up. Kind of lift up, good, and then I'll take your legs for you. Good. Let me get your legs out in front of you. Get your arms a little bit behind you, a little bit right about there. Okay. Good. And drop and rotate your head to the opposite side. Good. And leave some room for your arm there. Okay. Good. 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 Okay. How about if we just kind of go back to the center? This is good. Good. And one more. Let me set you up one more, and I'll let you rest. All right. Great job. And one activity we're going to show now is the ability to raise your rear end upwards, or raise your whole center of mass upwards to do an unlevel surface transfer. And Jason, why don't you just do a push-up up to this mat. The mat's about 4 inches up. And back down, good. And why don't you do a couple more of those? I want you to notice how Jason uses the head-hips relationship, very nice. By lowering his head down to the left, it helps wind up a lot of the connective tissue in his lower back and helps raise his rear end. And come back down again, good. You got another one in you? Sure. Head down to the left and relax. Now we're going to offer him a little more of a challenge by going up to double that height. And notice the importance that he's going to show you about the head-hips relationship and the hamstring range of motion length that allows that. Good. Head down to the left as his butt goes up and to the right. Good. And this obviously takes incredible strength in a lot of his musculature, particularly his scapulothoracic depressors. Head down and rotate down to the left. Great.
Like the long sitting position, the short sitting position is an important functional posture for a person with a spinal cord injury. Due to the reduced base of support associated with this posture, short sitting is inherently less stable than long sitting. Nevertheless, the ability to assume and maintain a short sitting position is a fundamental part of moving the body upward and laterally during transfer activities. These activities include transferring to and from a wheelchair, vehicle, bed, commode, and bath bench. Also, the short sitting position is very useful for providing challenges that enhance balance, strength, and overall functional mobility. This section includes the following topics: providing various therapeutic challenges in the short sitting position, and performing a push-up from the short sitting position.
We're going to show some issues that relate to short sitting posture. And one idea is to show how Brian can control his balance in this position with no functioning abdominals or trunk musculature, functioning at the C5 level. Place his hands on his lap. And how about to the side? Good, and your lap again. And back to the side. This just requires just repetition, working. And I'm going to give you a little bit of stresses here. See if you can't compensate for that. Good. So another practical way to deliver these stresses is actually have the therapist sit in front of Brian, facing him. Good. Brian also has to establish confidence in this position and just the ability to move freely. And this really carries over to to assistive and transfers. How about if we kind of walk your arms back and we'll go into shoulder extension on either side. We'll start with your right one here. Okay, plant the right one down, and then work on planting the left down. This is kind of an active assistive motion that we're doing here, and we just kind of work this together. And then over time, the therapist just backs off the assistance. Okay, now let's walk back up. Lead to your left and unload your right. Lean to your right and unload your left. Okay, good. And then he goes forward till he finds that point where his elbow is stable and held there by contraction of his anterior deltoid. Great. Let's do that again. Let's start with the right. Throw your right arm back. Now left. Right. Good. Lean to the right, unload, and throw your left. Lean to the left and unload. Good. And we'll reverse that. Good. So you unload one side and you move the other. That's good. And then once the head go far enough forward that you get that stable position. Okay. You all right?
Yeah.
Okay, and it's amazing to look at the stability that Brian has through the upper extremities. And this stability is only possible when you have nice hyperextendable elbows, about a 90-degree range of motion at the wrist to accept the weight, and to have a stable and strong glenohumeral joint, which is all possible at the C5 level. Okay, that's excellent. But one idea, it's really a high-level activity, is to be able to do a short sitting push-up and do a transfer. So you transfer your rear end from one mat to the next mat. So you actually do 180 degrees of rotation of a sitting push-up. And this really challenges not only this whole scapulothoracic depression activity, but it really pushes the whole idea of the head-hips relationship. The head goes down, the rear end goes up, or the head goes one way, the rear end goes the other. That's all driven by the connection of the passive elements in his low back. Why don't you, Bob, if you would, just to change your position 180 degrees so you're transferring your rear end from this mat to this mat, please. And note the importance of his extended wrist to act as platforms to accept this weight, his stable elbows, and the scapulothoracic depression he gets to do that activity. The short sitting position like this is a prerequisite for transfers, for activities of daily living. You really must be mobile and stable, as well as have confidence and balance in this position, so you can free your upper extremities for various manipulation and still have a stable upper body. So we're going to show a couple activities here that really will facilitate transfers, activities of daily living, and even all kinds of mat activities. This idea about putting her between two mats like this is really a safe and practical way to exercise as well. The first idea I want to show is I want to get in front of Jacqueline. And once she has really good short sitting balance, as she has here, we can progress then to doing an activity where she elongates one arm. Now make that arm short. Now we're functionally elongating this whole limb, which means that the serratus anterior is shortening and protracting this limb forward. And that protraction has to occur through a limb that has a stable elbow. And this is a definite prerequisite for any activities that require this type of scapulothoracic depression or protraction with a sitting push-up or a transfer. Okay, let's make it push really hard. Make your arm long. Now make it short. Beautiful. Make it long. Now short. Now when we're doing this activity on her right, we're really challenging the left shoulder as well, because her left shoulder now is actually getting a stretch, and she has to remain stable over her left shoulder. Okay, we do this a couple times, a good push. Now let's switch arms. Okay, now give me a good push. Good. Now this is required her to stay stable over that right shoulder as well as working on the scapulothoracic protraction on her left. Push. Good. Push. Now don't let me push you now. Hold. Now I'm giving her a very, very hard push now. Hold, 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 relax. Good. Let's switch arms. Good. Now push at me hard. Don't let me push you. I'm pushing as hard as I can, just about. Push, hold, hold. Beautiful. Now switch. Good. Now this is an excellent challenge for balance as well as just confidence in this position, because this position right here is definitely a component in the transfer. And a good stretch on the right shoulder. And one more. Switch. Make your arm real long, now short. Good. Real long, short. Real long, short, and relax. Great job. Good. And back down. How about another one? The head-hips relationship is essential here. And forward, and relax. So once you master the ability of raising your rear end up like this, the next idea is to start to challenge him side to side. And again, he will capitalize on the head-hips relationship. Not only is he going to lower his head, but by rotating his head to his right, he's going to help wind up a lot of the tissue in his lower back to help translate his body to his left. All right. So why don't we try that? Let's just work on just taking your rear end and just move it about 6 inches to your left. And show me that head-hips relationship here. Good. And then why don't you bring your legs next? And the whole aspect of manipulating your legs to follow you after you moved is very, very important. That requires that he's stable on his left side. Okay. Why don't you just slow down this a little bit here? This whole aspect of moving your legs requires that he can bear weight on this left upper extremity, and fortunately has triceps that helps lock the elbow, and then be free enough and be stable enough that he can then manipulate his legs with his other extremity, using primarily his wrist extensors and elbow flexors. And again, the confidence it takes is all part of this, that he's stable in this position. So I think what I'll do now, Frank, is I'll move your legs for you so we can kind of speed things up here. And what we'll do is, which is very helpful, is for him to actually do these series of sitting push-ups around the whole perimeter of this mat. This is very good to actually build endurance as well. Good. We'll do a short one right here. Okay, and I'll take your legs from here. Okay.
The preceding sections of this program have focused on the function of the individual regions of the upper extremity. Maximizing movement potential in persons with spinal cord injury, however, requires that the individual regions function together in a highly coordinated manner. This coordinated action is often demonstrated through the mechanics of pushing a wheelchair.
Kurt shows very strong C6 function on this left upper extremity. And some of the most important aspects of that C6 function are not only his very stable glenohumeral joint, his relatively stable scapula with an innervated serratus anterior and lower trapezius. This musculature really allows him to functionally elongate this upper limb. How about make your arm short? Now push straight out at me. Now make it short. And let's keep your elbow straight when you do it. Make it short and push. So not only does he have this important scapulothoracic protraction and depression component, but he also has a nice extendable elbow and a well-developed clavicular head of his pectoralis major and anterior deltoid that can keep his humerus horizontally brought towards the midline, which helps stabilize his elbow. The idea is to harness this proximal muscle force and push it distally as a thrust throughout this whole upper extremity. So not only do we have a stable elbow, and an elbow is very extendable even from a passive standpoint, he has very strong wrist extension. And the wrist extension really allows a mechanism or a platform to actually transfer this pistoning action onto some other object. Like a mat, for example, if you're doing a sitting push-up, or the wheel of a chair for manually propelling a wheelchair. Now we want to show this idea here. If you want to just push straight down like this, These are really important stroke mechanics for someone at the C6 level uses to manually push a wheelchair. And if you note, it really is, there's a large component of scapulothoracic depression involved. Push hard, that's it. Push. Now, if Kurt was at the C5 level and he didn't have such good glenohumeral stability and a stable scapula, he would push his chair by using much more of flexion mechanics, as shown like this. And very often, by use of rims or extended pegs, you can actually time your flexion to actually drive the wheelchair. But this idea right here uses more anterior deltoid and flexion, but it's not able to harness a lot more of the more proximal musculature that you're able to do at the C6 level. Because at the C6 level, you can get the extended wrist. The elbow certainly can be extended and held extended by more stable proximal musculature. And you have that more stable scapula, mostly driven by the serratus anterior. That muscles like the lower trapezius can actually push into a depression activity. So this activity is not only elbow extension, it really is scapulothoracic protraction and depression. So we're going to show these mechanics as Kurt actually pushes the manual wheelchair.